Hi, everyone. Welcome. I'm Christine Buckley, the host of the Brain Aneurysm Foundation's 1 in 50 podcast, here to raise awareness and provide education on a disease impacting at minimum 1 in 50 people. So thank you for joining us. Hey, welcome to Dr. Neha Dangayach, who's from Mount Sinai Hospital. How are you?
I'm doing very well, Christine. Thank you so much for having me.
Yeah, no, we're so excited because September's Brain Aneurysm Awareness Month, and we like to do anything we can in collaboration with the American Heart and Stroke Association. So we just figured that this would be a perfect time, you being a volunteer for them in many capacities, to talk with you a bit about the differences between brain aneurysms and strokes. So again, thanks, and we'll just get right into it.
Absolutely.
So can you please tell me a bit about your background that led you into neurology?
Sure thing. I'm one of those people who sort of knew from kindergarten that I wanted to be a doctor. I didn't even know how to spell doctor, but it's one of those things that you embark on a journey and you realize why you want to do something. And as I kept moving towards this goal of becoming a physician, I realized my purpose and meaning in life. And the more I kept doing it, the more validation I received for that purpose and meaning. Neurology happened to be one of those areas that I got really fascinated by in trying to understand the mind and the brain and how things interact with each other in a way to make us complex, thoughtful human beings, and how some of these diseases rob us and our patients of their identities, and what can we do to fix all of that, and what kind of a village does it take to
Yeah.
help our patients and families, because it's not just the patient gets affected, it's the patient caregiver dyad. So all of those things, and then finding some tremendous mentorship and sponsorship throughout this journey from neurology to neurocritical care and now at Mount Sinai. I just feel so grateful.
Oh, that's wonderful. No, and thank you for what you do, because in the short time that I've known you, it's just amazing how much you give to the patient community and the work that you do. And you touched upon a little bit the many hats that you wear at Mount Sinai, but can you talk a little bit more about the recovery care and that side of things?
Absolutely. So, as a neurointensivist, somebody who's working in an ICU setting, taking care of patients with very severe acute neurological injuries and seeing the impact on patients and their families, our first goal is obviously how do we save someone's life? How do we ensure that we uphold time as brain? But then, how do we resuscitate the person behind the patient such that it's not just survival, but the quality of survivorship? And how do we ensure that, just like we have this tremendous village that supports them when it comes to triage and hyperacute care, how do we ensure that we deliver care in a seamless manner for our patients and families during that survivorship journey? So that's what motivated me to think more about that survivorship journey, moving just from survival to improving the quality of life and multi domain outcome measures, physical, cognitive, mental health. Understanding not just the burden of all of these different problems that our patients and families will suffer from after they leave our ICUs, but what is it going to take? What is it going to take as a community to support our survivors after severe acute brain injuries? And that sparked my interest towards looking at innovations and digital health and systems of care, and how do we make our systems the way they need to be to support patients and families throughout this journey from triage to recovery. Hence, we developed this Neuroemergencies Management and Transfers program at Mount Sinai that I lead, with tremendous support from all of our different departments: emergency medicine and neurosurgery, neurology, radiology, so on and so forth, to get the right patient to the right place at the right time every single time. And then on the recovery end of the spectrum, how do we support our patient caregiver dyad in the survivorship journey with multidisciplinary care, right from ICU doctors to physical therapists to PMNR to spiritual care, pharmacists, so on and so forth, connecting them to all the different resources that they need in order to adapt to that new state of normal. So I just feel very grateful that I have amazing teams, all across, whether it's clinical care, whether it's research, whether it's
Right.
innovations, digital health. I just feel very grateful.
Yeah, no, I mean, that's all amazing. You kind of opened up a lot of different things, but sometimes people hear the term patient-centered care. And I think that's what you're talking about in all of this, and having, the care after they have been treated and moving forward in recovery. And I just think that there is so much lacking there. So I know Mount Sinai is a great hospital, and I know in the particularly Northeast corridor, there's a lot of great medical facilities. And I have heard from physicians, patient-centered care is something that seems to be front of mind. So could you just touch upon like that term a little bit more? And do you think that it seems to me you are part of a really great team? Do you feel that that someone's going to get the same care or the same full continuum of care into recovery everywhere? Or is it starting to improve at other centers? Just, a little bit more on that would be great.
Sure thing. And, I'll just take that term one step forward, patient and family centered care, or PFCC. When we think about patient and family centered care, how do we think of our patients and families as integral partners in delivery of care that's going to be in line with our patients' goals, values, wishes, and the best possible evidence based medicine, translating that and matching that up with their goals, values, and wishes? So, and upholding dignity, compassion, as much as scientific evidence. So, with that goal in mind, how do we create both our teams and systems to meet the needs of our patients and families to uphold patient and family centered care? Now, that's a goal that needs to be very intentional. Do health systems, hospitals across the United States at this time think of patient and family centered care as one of those aspirational goals for every single thing they do? I want to say, at some level, I want to believe, yes, we all go into healthcare wanting to do something like this and wanting to do right by our patients and families. But does it always happen? Do we have the systems and the resources in place to always uphold patient family centered care? There are going to be changes in our environment, or whether it's pandemics, or whether it's resource limited settings, which make this challenging. So I always remind our teams, as long as we're doing the best that we can do with the resources and knowledge that we have at that moment in time, we have done our best. As long as we can say that, then we're upholding patient and family centered care. And comparing ourselves to different centers that have a lot more resource, like Mount Sinai, it's a very resource intense health system. We're
Right.
very lucky. But we
Right.
can't say the same about a lot of other places in the United States. And for those care teams, I would just say, as long as you are doing the best that you can with the resources, knowledge that you have at that moment in time, you have done what you can do to uphold patient and family centered care.
Yeah, no, that's lovely. That's beautiful. I definitely agree with that. Do the best with what you have. That's all we can ask. And I just think, obviously getting people to the centers that can provide them the best care when they have these neuro emergencies. I know that you're also a researcher and you run your own lab. Can you touch on that a little bit in the work that might be related to brain aneurysm research?
Absolutely. And my research has evolved from a lot of my different roles, and there are so many synergies in what I do and how I take care of patients and families. And for me, the clinical care that I provide has been a great source of inspiration for my research. So I think of myself as a systems science researcher. I serve as the principal investigator of the Neuro Emergencies Management and Transfers Lab, or our NEMAT lab. And I wanted to create a milieu that would encourage innovation, leveraging technologies and innovation throughout, from triage to recovery, to provide compassionate care for our patient family dyad. And at the same time, mentorship happens to be one of my core values. I wanted to leverage multidisciplinary mentorship in the midst of this lab. Mount Sinai's milieu allowed me to partner fruitfully with different industry collaborators. And how do we move the needle for innovations, to accelerate innovations so that we can translate innovations to the delivery of care at the bedside? One of the things about evidence based medicine and clinical trials, which is hard, it takes years to translate the results of our clinical trials to
Right.
the bedside. And 17 years is what it takes sometimes to do this.
Wow.
It shouldn't take that long because it's just not an acceptable standard. That's what got me motivated to thinking about what can we do different and how do we accelerate the translation of rigorously collected scientific evidence to impact the care of our patients at the bedside. So that's what keeps me up at night for all neuro emergencies. How do we make our systems better? How do we support the teams that are providing all of this great care? How do we help them translate evidence-based medicine at the bedside? What are those barriers that we need to break?
Right.
What are the things that we can leverage to serve as facilitators? So that's been an exciting journey. We have lots of
That
great
is, it's a lot.
a lot
It's
of
a
great
lot.
skills, lots of great people we're mentoring, right from master students to PhD students to nurses to advanced practice providers to our trainees, residents, fellows. I couldn't have asked for a better, a better lab. It's a virtual
That's
lab,
great.
and it gives us a lot of flexibility in doing the work that we do.
That's amazing. Well, thank you for that. And as being an advisor in the American Heart and Stroke team, what role do you play in advocacy, and what do you think is, what is important to be advocating for both the stroke and brain aneurysms?
I think it's very important for us clinicians and folks who think of ourselves as clinicians, researchers, clinician researcher leaders, to advocate for our patients and families and teams. When it comes to resources that are needed to translate evidence-based medicine, that was one of my big motivations to get involved with the American Heart Association. I think they do a tremendous job of staying up to date with the most recent clinical trials, updating guidelines, providing the tools that frontline teams need to talk to their hospital health system administrators for the right kinds of resources, showing the hospital administrators, policymakers, what is meaningful and why we need to drive change and why we need to challenge the status quo. So I think the American Heart Association, American Stroke Association has done a great job of putting out these guideline statements, these practice statements to help frontline team providers. For me, serving as a writing team member for the subarachnoid hemorrhage guideline statement was very fulfilling at multiple levels. I got to work with leaders, thought leaders who are thinking about challenging the status quo, and how do we highlight what are those gaps? Where do we need to go from here? We have made strides in improving survival, but how do we improve survivorship? So that resonated with me quite deeply, and I found that to be a very meaningful experience. Then we worked on these outcome measures, performance metrics for when you provide, as a center, when you provide care for subarachnoid hemorrhage patients, what are those things that are meaningful for you to measure as a center in order to show that you're doing the right thing for your patients every single time? And when we think about performance metrics, it's hard, when people hear the word metrics,
Right.
it can be jarring that we're not just doing things to meet a particular metric. But I'd like to flip the narrative. If we don't measure what is meaningful, we're not going to know whether we're making progress. And
Right.
if we're not making progress and not meeting a particular meaningful metric, then we've got to revisit, go back to the drawing board as a team and figure out, take that as a learning opportunity. What can we do better? That was another reason why I found the engagement, the way American Heart Association has thought about acute ischemic stroke, about intracerebral hemorrhage, how they're thinking about subarachnoid hemorrhage and translating evidence to the bedside and helping teams measure that which is meaningful, has been a great journey.
Right. Well, that's great stuff. Yeah. I mean, at doing advocacy work, we go to the Hill once a year for legislation that we have called Ellie's Law, trying to get more brain aneurysm specific research funding through NINDS. And sort of like research itself, that's a journey and it takes many years. But just to be there to advocate and raise awareness and support the patients and families that are, impacted by these diseases is critical. So thank you for all the work that you're doing on that end of things. Then I want to talk a little bit about the just level of awareness and the difference between brain aneurysms and stroke. People know the BFAST system and program, which is great, but it doesn't really exactly apply to brain aneurysm. So, brain aneurysms are impacting 1 in 50 people, is a very conservative number walking around. So the prevalence is there. So what do you think about the gap just in overall awareness and education between stroke and brain aneurysms, and how maybe we can all work together to kind of shrink that gap down a bit?
No, I think, Christine, what you said about your advocacy work, I hope everything that we do with the American Heart Association, American Stroke Association provides you with the kind of background support in both
Yes.
literature, in what you need to advocate for to support our patients and families, and making sure that the community is well educated on what it means to have an aneurysm and why it's still one of the deadliest forms of stroke. And it is a form of stroke. I think it's very important to emphasize that right from community education, advocacy efforts, as well as how we publish our literature and disseminate that literature. Why is there this gap? I often reflect on this both in terms of community education as well as research and how we develop our stroke systems of care. It almost seems to me that acute ischemic stroke, yes, 80% of our patients are going to have, when they have a stroke, it's going to be an acute ischemic stroke. About 15 to 20% will have hemorrhagic stroke. Of those, about 10 to 15% are going to be intracerebral hemorrhage, and a smaller percentage, about 5 to 10%, will be subarachnoid hemorrhage, depending upon where we look at this data in the world. 1 in 30,000. We're seeing a total of about 30,000 patients, adult patients, in the United States every single year with aneurysmal subarachnoid hemorrhage. Having said that, it is one of the deadliest forms of stroke, reminding people that aneurysmal subarachnoid hemorrhage is a form of stroke.
Right.
The acute ischemic stroke literature, systems of care moved much faster as compared to intracerebral hemorrhage and aneurysmal subarachnoid hemorrhage. And that's probably why our stroke systems of care are so good at taking care of patients with acute ischemic stroke. We're lagging behind on hemorrhagic stroke simply because our research efforts and our translation of those research efforts at the bedside did not match the same pace as what was being done for acute ischemic stroke. But that narrative is changing. We know that is changing because there are several amazing research efforts around intracerebral hemorrhage as well as around aneurysmal subarachnoid hemorrhage. And that, I think, is going to be the linchpin in changing this sort of lack of awareness and
Yeah.
misconception that aneurysmal subarachnoid hemorrhage is not a stroke. And hopefully, when we talk again in the future, in
Yeah.
the past, we somewhere have worse headache of someone's life as
Right.
one of the, as one of those capturing messages that remind patients to go to the ED, call 911 when you have the worst headache of your life.
Okay. No, thank you for that. And just too, for people who are listening, can you just give a brief description of the difference between an ischemic and hemorrhagic stroke? Because people
Absolutely.
hear different terms and they just get a little bit confused sometimes.
Yeah, no, and not just the lay people. I think even in the medical community, one thing we have to acknowledge is just based on clinical signs and symptoms, it's very hard to distinguish between what is going to be an ischemic stroke and what is going to be a hemorrhagic stroke.
Right.
For an ischemic stroke, there needs to be a blockage in one of the blood vessels, whether it's a large blood vessel of the brain or whether it's a small blood vessel of the brain. There needs to be a blockage in a blood vessel for ischemic stroke. That leads to lack of blood supply to a vital area of the brain that leads to the symptoms of a stroke. As opposed to hemorrhagic stroke, where we talk about two big types of hemorrhagic stroke. One, which is intracerebral hemorrhage or bleeding in the substance of the brain, which could happen spontaneously. For example, a patient who has underlying high blood pressure could bleed spontaneously because of a rupture of some of the smaller blood vessels in the brain, as opposed to aneurysmal subarachnoid hemorrhage, where there is a pre existing weakening of one of the blood vessels of the brain. And that weakening of the walls of one of the blood vessels of the brain leads to the formation of a little balloon, which is called an aneurysm. And that balloon can burst at any time. Why does that balloon even form? While we understand some of the risk factors, we don't fully understand why some people have these aneurysms right from birth. So there are some genetic factors as well. But lifestyle factors like high blood pressure, smoking, that can increase the risk of having aneurysms or increasing the size of pre-existing aneurysms and increasing the risk of rupture of those aneurysms. So when those little balloons, which are weakening in the blood vessel wall, burst, there's bleeding that goes into the coverings of the brain. The brain has these envelopes, and when it goes into the coverings of the brain, that's when it's called subarachnoid hemorrhage. Because there's a spectrum for all of these strokes can have a spectrum from being asymptomatic, like no symptoms at all, to very severe symptoms that push a patient into a coma. And that can happen particularly with hemorrhagic stroke more than what it happens with ischemic stroke. So understanding that when someone's developing either either weakness of one side of the body or the other, difficulty with speech, vision problems, or dizziness, difficulty in walking, worst headache of their lives, they're vomiting, they are losing consciousness. All of those signs could very well be a sign of either ischemic stroke or hemorrhagic stroke. And when I say ischemic stroke, these kinds of signs where somebody loses consciousness and they slip into a coma. For ischemic stroke, it will usually be a problem in the posterior circulation, one of the arteries that's called the basilar artery. For hemorrhagic stroke, it could be a large amount of bleeding in the substance of the brain or in this vital area of the brain called the brain stem. For aneurysms, there's a very specific thing that can really push somebody into a coma right away with bleeding into what are called the ventricles. So, in addition to the coverings of the brain, the ventricles, which are normally filled with fluid that surrounds the brain and the spinal cord, that can cause increase in the size of these ventricles called hydrocephalus and push somebody into a coma. So I think it's important to educate our patients and families that, hey, look, just based on the signs and symptoms, we're not always going to know clinically whether a patient is suffering from an ischemic stroke or hemorrhagic stroke. Often the risk factors are going to also be similar: high blood pressure, somebody has uncontrolled diabetes, they're a smoker. Um, Aneurysms tend to affect more of our younger patients as opposed to patients with intracerebral hemorrhage and acute ischemic stroke. But
Right.
reminding our patients and families that, hey, you really need to get to the hospital quickly so we can figure out, based on CAT scan imaging and CT angiogram, essentially imaging of the blood vessels, what kind of stroke your loved one is suffering from, or reminding the patient what kind of stroke you're suffering from so that we can then provide time sensitive treatments, because there are time sensitive life saving treatments available for all stroke types right now.
Right. Yeah, no, that's all good information. I mean, one thing I struggle with a lot, particularly when we go to the Hill and you are trying to advocate and give people the appropriate information. And there's some decent statistics, but I think the mystery of the brain aneurysm is there is no definite answer to why they form, when they form. If you have one, will it rupture or will it stay there the rest of your life? So it's a very tricky, I think, condition. And part of that too, leading into that, is like the screening issue, right? Like the underlying rule of thumb right now is that it has to be 2 or more people in a family before an insurance company will willingly cover that scan. And when we talk to different people, they're always like, why would you wait for that second incidence of somebody where it is genetic in about 25% of the time? So what are your thoughts on the screening or the hopes for one day there being a blood test that would make it more accessible? And more readily available to folks that do have someone in the family.
I think you bring up some really great points, and that's why it's been so hard, both from an educational perspective, research perspective, as well as advocacy perspective. How do we move the needle in making sure that people have access to the screening tests they need? Right now, the gold standard for screening for aneurysm still ends up being imaging. So it could be a CT angiogram or MR angiogram, but it still ends up being an imaging test. Are we close in developing a blood test that can screen for unruptured aneurysms? Because prevention is so much better than trying to fix the aneurysm, ruptured aneurysm, and its consequences
Right.
for our patients and families, right? So there are lots of promising research avenues that several researchers in the United States and across the world are exploring. And I'm hopeful that in our own lifetimes, there will be a blood test for screening for unruptured aneurysms. The other exciting avenue is the analysis of these aneurysms, both for flow dynamics as well as which aneurysm really needs to be treated and what kinds of treatments are available. There's so many great advances on being able to treat aneurysms that were previously thought of as being
Right.
either very very difficult to treat, or you absolutely needed to get a neurosurgical open neurosurgical procedure. But a lot of these aneurysms are now accessible by way of minimally invasive treatments or endovascular treatments, where
Right.
teams just go up with a catheter either from the groin or from the wrist, and they're able to fix these aneurysms with a lot of novel devices, whether it's smart coils or different kinds of stents or flow diverters. There's so much promise. So then, if we're able to detect aneurysms early, then we also know we need to pair that up with which aneurysms, once you've detected them, which aneurysms are okay just being monitored, because they have
Right.
a very, very low risk of rupture or no risk of rupture. So the risk stratifying appropriately so that people don't get over treated either. So the
Right.
folks who are doing this kind of research are also being very thoughtful in leveraging technology, artificial intelligence, secondary analysis of imaging to understand flow dynamics within these aneurysms, to identify appropriately which aneurysms, which are unruptured, need to be treated and which need to be monitored.
Okay. And that's, we talk to people all the time, like the early detection is really the key. But what we want to do, you can't prevent an aneurysm per se, but you can prevent the rupture through early detection. And that's the same. The treatments are getting better and better and better. And to your point, we know people that have had one, that have ruptured, had another second aneurysm that was found, but they were told it's too dangerous to treat right now. We want to watch it. And, then 5 years later, someone particularly I know, then they went in through the wrist to treat that second aneurysm that 5 years ago they weren't so sure they could get, and he's doing fine. So it is amazing. So that is why like that early detection is critical, because the treatments are getting better and better. But in terms of lifestyle, you mentioned high blood pressure, smoking, we know are things that definitely contribute to probably aneurysm formation and rupture. And people ask us all the time, is there anything else in their day-to-day life that they could do that could potentially, help, eliminate the fact that they may not get one, or help prevent a rupture if they do have one?
I think one of the most challenging aspects of modern medicine, both in studying this and providing appropriate, preventative measures and therapies, is stress. the stress of leading our routine lives and how we handle this. And I often say this about stress, there's good stress and there's bad stress.
Yeah.
And a certain amount of stress is needed for us to thrive as human beings to the fullest of our potential. But at the same time, how we cope with our daily stressors, because those daily stressors and our ability to reframe some of these stressors in a manner that's going to help us towards more positive growth and move away from some of those and form positive habits around
Mhm.
our lifestyle and lifestyle modifications. um, those are going to be so much more meaningful, not just in terms of the aneurysm itself, that milieu that we create in our bodies around that aneurysm, whether it's high blood pressure, coronary artery disease, smoking. We now know that there's a lot that has to do with stressors in our lives and inflammation. And the drivers of inflammation in the body also are tied into a lot of lifestyle factors. So physical activity, what are some of those things that can really help us, protect ourselves and build. Almost think of these, life's essential eights that the American Heart Association has also come up with as sort of a vaccine and building immunity against
Right.
a lot of different diseases that are intertwined. Although we think of that as an index disease, the aneurysm may be one thing, but what led to the aneurysm to rupture would have been high blood pressure. And why did somebody develop high blood pressure? Could have been because of the stressors in their lives, in addition to preventing them from leading a healthy lifestyle, whether it's exercising or eating a healthy, well balanced diet, or having social interactions, so on and so forth. So I feel like everything is connected to everything in some,
Yeah, I agree. Yeah,
and
that
making
makes
sure that
sense.
we're intentional about it. Like, this is what we want our lives to look like, and how are we going to mitigate some of those bad stressors and make sure that we make the most of the good stressors in our lives.
Right. Oh, that's great. Later this month, we'll be having our annual research grant symposium. So, the Brain Aneurysm Foundation is the largest private funder of brain aneurysm research. So, we're proud of that. And we're going to be giving out close to $600,000 to 14 different projects. So, we just look forward to that every year. And we have the scientific session where the prior year researchers meet and spend the day with the current year researchers. And there's been a lot of collaboration that have come out of these meetings, from someone in California working with somebody in Buffalo. So it is great to see, these young people, for the most part, just really working hard to make things better for the future patients and families that are impacted by this disease. And I really think that that's the key, just, keeping families and communities whole by preventing these ruptures. So just sort of as we're wrapping things up, what do you think we kind of talked about the blood test, but is there anything else that you think is like something big that could come up in research in the next, say, 5 to 10 years? And, what would your hopes be for the future of this disease in the next 5 to 10 years, or something that might be a big change?
First and foremost, congratulations to the Brain Aneurysm Foundation for being such an important part in moving the conversation forward, moving the field forward by funding a lot of meaningful projects. So I hope you continue doing that for many, many
We
years
will.
to come in the future. When I reflect on the continuum of care for patients with subarachnoid hemorrhage, their families and caregivers who get impacted by a ruptured aneurysm, we need to be thinking about research across the spectrum. The preventative care aspect is imperative. It is very, very important. But for all of those patients who have aneurysms that are detected and diagnosed, the stress that comes with knowing that you have
Mhm.
an aneurysm that could rupture at any point in time and we don't know when it could rupture, that can be very stressful for patients and families and their entire universe. So, how do we ensure that we have the appropriate kinds of support systems that are built into place, whether it's peer-to-peer support, whether it's leveraging different technological platforms, whether it's leveraging wearables, digital technologies, in order to help our patients and caregivers who do have an aneurysm that's diagnosed, but it hasn't met the current threshold for treatment.
Right.
And also those patients who've had ruptured aneurysms in the past, but who have additional aneurysms, because we know the number one risk factor for another aneurysm rupturing is a prior aneurysmal rupture. So, how do we create this layer of holistic health and support for them? So, I hope there's going to be more work that'll happen in that realm, both to help our aneurysm survivors, patient caregiver dyads, as well as those who have unruptured aneurysms who've had that detection. How do we support them better and leverage technology there with wearables, digitals, to give them these sort of warning signals? Hey, your blood pressure is not being measured appropriately, or your stress levels are high.
Right.
These systems of care, what I'm really, really hoping is going to happen in the next 5 to 10 years, just like acute ischemic stroke research accelerated the formation of stroke systems of care around time is brain and door to needle time and picture to puncture time, all of these time sensitive measures that became part of how we deliver care. I am very hopeful the same is going to happen for hemorrhagic stroke and particularly for aneurysms. When patients present to centers that do not have the ability to
Right.
treat these aneurysms, and by ability, I mean that village, that team of
Yeah.
neurosurgeons, endovascular specialists, neurocritical care specialists, stroke specialists, and that entire village of PT, OT, speech, nutrition, etc., that needs to support that patient, that these patients are transferred rapidly. And when they're being transferred rapidly from one place to another, how do you prevent those patients from deteriorating? Again, leveraging technology in the back of the ambulance, whether it's wearables, whether it's integrated data feeds, whether it's providing real-time guidance to our ambulance team members, and making sure that they're monitoring for all the right things and are able to institute rapid treatments in the back of the ambulance, whether it's blood pressure control, whether it's ICP or raised intracranial pressure monitoring, whether it's titrating different drips in the back of the ambulance, or how do you transport patients who've had severe hydrocephalus and need a drain in place? How do you transport those patients safely from one location to another? So I'm hopeful that in the next 5 to 10 years, we're going to see a lot of advances in the pre-hospital realm for managing these patients who are very, very sick and for whom time is brain, but we have not been able to leverage that time is brain paradigm for our aneurysmal SH patients as much as for our acute ischemic stroke patients.
Yeah.
Within, yeah,
No,
please.
that's great. No, go ahead. I just say I love all of that. I think it's incredible what you're doing, and the team that you obviously must have around you must be invigorated by you and working with you. But I agree. Just it's like about the patients and the families, and it's not like, again, we always say it's the 1 in 50, but that one is connected to so many other people.
Many
So I
others.
do so much agree with the patient and family centered care. So much more has to be done in the recovery and the rehab piece of everything. So I just think what you're doing is amazing. I can't thank you enough for taking time to be part of this podcast to get more information out there, particularly during September, our Brain Aneurysm Awareness Month. I mean, you're doing amazing things. I'm just so happy our paths have crossed, and I hope we can keep some conversation going to work together more often to make things better in the future. But you are certainly doing amazing things, and I can't thank you enough.
Thank you so much, Christine. And the last thing I'll say for partnerships with industry for accelerating innovation, partnership with organizations like yours, the fact that we have such an amazing platform with the American Heart Association, Stroke Association, to bring together thought leaders in all aspects, right from community education to health systems to thinking about innovative solutions to doing randomized control clinical trials. And I'm very, very hopeful in the next 5 to 10 years, we're going to see a great platform randomized control clinical trial that tests a lot of different interventions for aneurysmal subarachnoid hemorrhage patients while they're still in the hospital, where we're able to then customize care. One size doesn't fit all for all the
Right.
different complications that our patients can suffer from. How do you predict how do you use artificial intelligence, machine learning to personalize some of this care? And you tie in all of that genetic genomic research that is happening, that is so promising, and it's happening across the United States, bringing everything together. I think the big message is, I think everybody will benefit from bringing everything together in a manner that's going to help us move the needle for improving bedside care delivery and across the spectrum, without letting anyone fall through the cracks.
Great. I mean, you've provided hope for anyone listening to this in the future of this disease. And, I'm on board to be part of any team that can help make this happen in any small way. I can be a part of it. But again, I appreciate you for your talent and your expertise and the passion that you have to make things better for the brain aneurysm community. So again, thank you so much.
Thank you so much for having me. And thank you for everything you do.